We're here today to give a mid-year update on what's happening with Nebraska hospitals. And we're honored to be joined by three leaders in healthcare. First, we'll be joined in a minute by Dr. Harris Frankel, Chief Medical Officer of Nebraska Medicine in Omaha. Then we'll hear from Jeff Francis, Vice President and Chief Financial Officer of Nebraska Methodist Health System. And then finally, we'll hear from Jed Hansen, the Executive Director of the Nebraska Rural Health Association. In this mid-year update, we're going to look at the challenges that our hospitals are facing, and the challenges that Nebraska hospitals are facing are reflective of what we're seeing across the country. And unfortunately, it's a very challenging environment. Just last week, 3 hospitals closed nationally, one in Michigan, one in North Carolina, and a hospital that operated for over 150 years in St. Louis, Missouri, closed its doors. And these examples need to be a wake-up call to our policymakers at the state level, at the federal level, and community leaders. A wake-up call to understand what's at stake when hospitals close their door and the economic impact and the impact to healthcare services that can have. As I said, in Nebraska, the environment remains incredibly challenging for hospitals, and the economic outlook for some remains bleak. We recently conducted a mid-year survey in July and found that about half, 48% of Nebraska hospitals were operating in the red, were running a negative operating margin. Now this number is down just a touch from where it was 6 months ago when it was 55%. So we went from 55% of hospitals 6 months ago running a negative margin down to 48. Maybe someone could say that looks like good news. The bad news is, from all indications, those hospitals that are in that 48% that are running a negative margin have been running that negative operating margin now for multiple quarters on end, and some reaching well back into 2022 and even before that. The outlook for 2023, for fiscal year 2023, remains challenging or very challenging for 73%. Almost 3/4 of our hospitals in the state say this year's finances are challenging or very challenging. And that comes on the heels of the 2022 fiscal year, when the average net operating margin for our hospitals was in low single digits. And that's the average. So obviously many hospitals ended fiscal year 2022 running in the red. And the question then becomes, well, what's driving this? And when you look at a hospital budget, and we'll hear from our guests here shortly about what they're seeing, what they're feeling, about half of a hospital's operating budget or even more is labor, is the cost of their workforce. And right now we have nearly 90% of Nebraska hospitals reporting a workforce shortage, including in that 90%, 100% of our large tertiary hospitals in Omaha and Lincoln, and 100% of our regional referral centers in mid-sized communities like Scottsbluff, Norfolk, North Platte, Kearney, Hastings. So the workforce challenge continues to be a tremendous problem, with registered nursing, nurse aides, and laboratory technicians being the greatest need. The average hospital says they're about 8.7% understaffed. That's very close to where it was 6 months ago when it was our number was 9.2%. So we're not making a lot of progress towards the understaffing that's happening. And we even had some hospitals reporting shortages of over 20%, so a fifth of their workforce being short-staffed. So again, this is really an opportunity for us here to talk about what's happening and to make sure that the public understands these challenges, as well as those people that are making policy decisions. As many of you remember, we worked very hard in the legislative session to try to increase provider rates, and 3% provider rate increase went into effect on July 1st. That doesn't quite meet the growth in costs as we try to take care of a high growing cost of workforce, cost of pharmaceuticals, cost of supplies. And also just recently, the federal government came out with its reimbursement rate for the next fiscal year or next calendar year, actually, of 3.1%. So again, falling short of what's needed. So the financial challenging situation that our hospitals are in isn't right now being solved by policymakers. And our hospital leaders are doing the best they can to manage their way through it, but we continue to try to make that voice heard to our elected leaders. With that, we're going to hear from our guests and hear what's happening in their facilities or other hospitals around the state, both on finance, workforce, and other challenges. So I'll turn it over to Dr. Frankel. Go right ahead.
Jeremy, thank you very much, and thanks to NHA for hosting this this press conference. Jeremy's done an excellent job in summarizing the issues we're all facing. I'm Harris Frankel. I'm the Chief Medical and External Affairs Officer for Nebraska Medicine, the clinical partner to the University of Nebraska Medical Center and the College of Medicine. I think Jeremy has accurately highlighted the challenges that we all face. And as an academic medical center, we are certainly not immune to the financial challenges and workforce issues that he so aptly described. Let me talk a minute about financial sustainability from our perspective, and then I'll make some comments about workforce and workforce stabilization as well, and then I'll turn it over to my colleagues. You know, as Jeremy alluded to, the financial pressures that hospitals and health systems are facing are unprecedented. Really now entering the fourth year, if you will, since the pandemic began in early 2020. We face uncertainties about performance measures on value-based contracts. We have downward pressures from our payers. We have the increased cost of labor driven by the opportunity for traveling nurses during the height of the pandemic, where we lost a significant portion of our labor force to traveling opportunities for these nurses, where they were being paid exceptionally high numbers. And, you know, we had to contract with traveler agencies to fill gaps in those areas where we had nursing shortages. We still have about an 11% vacancy rate for our frontline nurses, and that number is probably a little higher if you add in all of the other non-nursing clinical care positions. Put that against an environment that has become very competitive for clinical labor. It's made for a very interesting task from an expense side of the equation, while still being able and wanting to deliver the same cadre of services and the quality of care that we've always aspired to here at Nebraska Medicine. The other thing I would say is that driving increased costs on our side and giving us financial challenges are and has been the inability to discharge medically stable patients who are ready for discharge, but who need another level of care beyond the acute care facility, as they may not yet be able to go home. So whether that be a skilled facility, a long-term care facility like a nursing home, or an acute rehab situation, these problems are not unique to acute care hospitals. And in fact, they have pervaded our long-term care and skilled care partners across the state, and they face the same challenges we do. And because of that, the availability of beds and access to those facilities has become constrained as well. You know, we are a mission-driven organization, and you've heard the saying, no margin, no mission. That's very important to us because we depend on the margins that we generate through our clinical services and care delivery to fund other programs, to fund education, to help support clinical research, all of which are important to all of our healthcare partners across the state, region, and nationally. So we are keenly on a daily basis thinking about these two issues, which really represent two of our top three issues, the other being access. On the workforce side, as you've heard and as I've partially addressed, the labor market has been exceptionally tough. It's been very competitive. The price of labor has been unquestionably the highest it's ever been. That places not only financial pressures on the institution, but also pressures to find quality people to provide the care we so depend on. We have taken upon ourselves a number of initiatives to address the workforce shortages, focusing on recruitment, retention, care redesign, so that we make certain that our workforce is operating at top of license across the board. We're looking for ways to leverage digital opportunities where it might help support the workforce. We're also looking at things, as I said, to enhance the experience of our workforce. We understand that the health and wellness of our workforce is incredibly important. As you're probably not unfamiliar, much of the workforce experienced quite a bit of what I would say mental health setback during the pandemic, stress and strain of caring for the COVID patients, not to mention the volumes of patients that are in our facilities for quite some time now. So we're really focused on not only the strategic and tactical maneuvers to try to maintain a strong and competent workforce, but also making certain that we are in touch with their health and wellness, what we can do to improve their experience and retain those workers and help them be our chief recruiting officers as well, to bring in additional workforce support that we so desperately need. I'll conclude by saying that in my opinion, there's not a better place to work than in healthcare, but as you might imagine, while it's never been a better time to be a patient, it's never been a more difficult time to be in healthcare. But I'm confident that we will continue to manage through this and end up on the brighter side of things. So with that, I'll turn it over, I believe, to Jeff Francis from Methodist.
Real quick before Jeff goes, if any media partners have questions, please put those in the chat, and when we get through our presenters, we will take those questions. So go ahead, Jeff.
Thanks, Jeremy. Thanks, Dr. Frankel. Going to hear quite a bit of what Dr. Frankel talked about applies also with Methodist Health System. Our operating margin is below the pre-pandemic or at or below the pre-pandemic levels. We're fortunate that we're on the higher end. We have a positive operating margin, but it's still not at the level that we need to be able to reinvest in our facilities, in our medical equipment, so that we can care for the patients in 5, 10, 20 years down the road. We're seeing the challenge with inflation. We're seeing it in technology costs. We're seeing it in supply chain, same thing with salaries. We're in the position in healthcare where we're not able to increase our revenue. The government tells us what we're going to have, and you can, as Jeremy pointed out, it's below what inflation has been running. On the private insurance companies, those are usually multi-year contracts. So again, not able to have the revenue to offset some of these expenses that we're seeing across the board that are up. Biggest challenge is definitely staffing within healthcare. Patient side givers, we're seeing a change. We've seen some that used to be employed move over to the contract labor, have gone into that gig economy. We're starting to see a little bit of reduction in the contract labor, and it's mirroring our ability to hire employees. So hopefully we're seeing some of the caregivers recognize that value in working in a team and going into the same unit day after day, and not just having those 90-day assignments. And from the long term, we are going to have challenges with staffing. The patients are getting older. They're coming in sicker. They have multiple conditions impacting their health, and it's making it tougher on those caregivers. So we're doing everything that we can at Methodist Health System to attract employees. Our talent acquisition team is reaching out to find employees in ways that we haven't done in the past. We hosted a healthcare camp for middle schoolers to interest people earlier for a possible career in healthcare. Our Nebraska Methodist College continues to work with an Upward Bound program to find more students that will go into college that wouldn't traditionally go into that path. The college also works on creating CNAs and the certificates and coordinating with Methodist Hospital to have a working opportunity so the students can work and learn at the same time. And then we're fortunate that Nebraska Methodist College is graduating over 100 nurses this summer. And so we'll be able to help out Methodist Hospital, but also those throughout the region. So with that, I'll turn it back over to Jeremy.
Great, thank you. And thank you, Jeff. Very informative. Now we'll go to Judd Hansen, who's the Executive Director of the Rural Health Association, who engages with a lot of our rural hospitals and has been traveling the state and certainly can report in on what he's seen at our rural critical access hospitals. Go ahead, Judd.
Yeah, thanks, Jeremy. Again, my name is Jed Hansen. I'm the Executive Director for the Nebraska Rural Health Association. And I'll start by echoing the comments made by Jeremy, by Harris, and Jeff. Our rural hospitals and clinics are hurting. Inflationary forces that are really we haven't seen in over 40 years, coupled with the unprecedented workforce challenges that we've mentioned, really hit our medical communities across the state with a 1-2 gut punch. Over 70% of our state's rural hospitals indicate, as Jeremy had mentioned earlier, a current financial landscape that's either challenging or very challenging. And this correlates with some of the national data that we have available to us, where nearly 2/3 of our rural hospitals recorded strained financials, with just over 50% at 52 recording negative operating margins last year. Moreover, 83% of our critical access hospitals and 100% of our rural regional hospitals, as Jeremy had mentioned, stated workforce shortages in nursing, environmental services, lab, and other clinical areas. And simply put, the challenging financial and workforce environment means fewer clinics, fewer OB and maternal services, less mental health assistance, and fewer hospital beds across the state. And really, these statements are not hyperbole. They speak to the real issue that we're facing. In the past 2 years, our state has experienced 1 hospital closure and 3 rural health clinic closures. And we've also seen contractions in mental health services and OB services. And more of our rural communities will continue to experience these reductions in services and losses in clinical and hospital care in the coming years if we don't do anything. While I remain optimistic with the increases in the federal and state payment rates over the next couple of years, as Jeremy and Harris and Jeff had mentioned, we really need to look at what we can do at a greater clip to face these headwinds. And currently, our healthcare leaders, those speaking today and others, are engaged with our state and federal officials on payment models, workforce scholarships, and other innovative care models. But one area that remains of particular concern to me is the federal 340B program. This is a program which helps hospitals convert medication dollars into community assistance programs, and they've really come under attack over the last couple of years by pharmaceutical lobbyists. Last year, our rural hospitals lost on average, between $500,000 and $1 million in program non-compliance by pharmaceutical makers, meaning that these pharmaceutical makers just weren't paying the dollars. And those numbers are far greater in our tertiary care centers and urban hospitals. But we need help to assure these dollars can flow into our rural communities for elder care, things like transportation assistance, dignity of life services, and more. So, some real headwinds out there, but I think that we've got a really good group of healthcare leaders in this state, and we're aware of these issues and we're ready to face them. Just to close, I love rural health, and I know the impact of local care and what that has on the health and wellness of our state's rural communities. And I'm looking forward to working with Jeremy, with Jeff, Harris, and others, so that together we can improve the health of our communities all the way from Douglas County to Dawes County in the Panhandle. Thank you.
Thank you, Jed. Good input. We'll go ahead and dive right into questions here. First, we had from Julie Anderson, what downward pressures for our payers? Does this mean insurance companies are seeking to pay less? I'll probably go to Jeff here in a minute. Certainly what I've heard, one of the biggest concerns from our membership is just the growing administrative burden. Certainly the negotiation side takes place, but the administrative burden, the steps for prior authorization, and that has certainly grown even more with the expansion of Medicare Advantage. That is not only adding costs, but it's also standing in the way of services being provided. And it's having a tremendous impact on that. And that's something that our association is starting to work on, putting together a more robust report on that. And we'll be shining a light on that a little bit later this year. But Jeff, go ahead and you can tell us about any more things you're facing from a CFO perspective.
Yeah, we definitely are seeing the pressure on the additional administrative side, the denials that are coming through, some of it from a technical standpoint, some of it from a clinical standpoint, but all those require rework on our part within our staff that's taking resources, taking dollars that is allowing us to get the money that we feel are due back for the services and the care that we provided, as opposed to those dollars that could go back into the patient side care, which is where we want to do that. All of us, especially with the not-for-profits, the dollars remain in healthcare. So the less that we can do on the administrative side, the more we can do on the patient care side.
Chad or Harris, would you add anything to that?
Yeah, I would just add, Jeremy, you mentioned in your opening remarks about the increased payment from state Medicaid at 3%, and I think you may have mentioned the Medicare increase on the IPPS at 3.1%. And while those increases are much appreciated, they don't come close to being able to cover the delta of our increased cost to deliver care. And so whether it be pharmaceuticals, other supplies, et cetera, and certainly the increase in labor costs because of contract labor, those increases, and similarly on the commercial payer side, the increases that we've been afforded come nowhere near covering the delta relative to the increased cost side of the equation. And I think Jeff highlighted, the other key point, which are the administrative hassles that we're all subject to and the expense tied thereof. So you put it all together, we are having to figure out ways to work in a very constrained economic environment.
Yeah, and I'll just add to what Jeff and Harris are talking about, and particularly on the clinical side. The types of pressures that we're seeing. We have patient, care. We have prescriptions that normally we would be able to easily get through, and in some cases, these are alternative care therapies to opioids, and they're being denied. And so when we just look globally at the challenges and the time constraints for clinicians, that adds to longer wait times. You may not be able to get into your local clinic to see your healthcare provider, your family physician, as early as you'd like. That places pressure on our urgent cares and our emergency departments. So there's a downward and a downstream effect to a lot of these pressures that we're seeing. And in our rural communities, every little bit of time matters. We have a lot of workforce constraints and having to do unnecessary administrative work that just takes away from everything that we are able to do.
Next question, are there any specific concerns regarding Lincoln hospitals? I'll take this, given the fact we don't have anybody from Lincoln on. I can certainly say that what we're hearing from hospitals in Lincoln is similar to what we're hearing from Methodist and Nebraska Medicine here on this call. The financial challenges are growing. The workforce challenges, again, fall in line with hospitals being around 10% on average understaffed. Hearing quite a bit from our Lincoln hospitals about post-acute placement challenges, not, again, much like Dr. Frankel said, not being able to get patients out in a timely manner. They're ready to be medically discharged, but for various reasons, either not having the capacity in our skilled nursing facilities. A lot of times it's behavioral health challenges, patients that have additional care management needs that can't be met by the current capacity in skilled nursing, or guardianship related issues. We are losing thousands and thousands of hospital days every year across the state. Last year in 2022, the number was over 35,000 avoidable hospital days that a patient sat in a hospital bed unnecessarily. So those are days that hospitals don't get reimbursed for, even though they're continuing to provide a very high level of care. So it's a issue. Again, we worked on that extensively this legislative session, passed a few pieces of legislation that are kind of starting to get moving, including a pilot grant fund that we're working with the state on. So we're hopeful that we can make some progress here, but there certainly continues to need to be some significant focus and investment on that skilled nursing sector that we're talking here, to make sure we can move patients to the right setting when that's what they need for care. Next question, and again, if you have any other questions, please put them in the chat. Given the rather bleak conditions, do you have any information? Would be a warning that any particular hospitals in rural areas may be closing. I think Jed mentioned certainly those service lines. There's been some national metrics that have been put out there that we do have several hospitals that have been running negative margins for multiple years, and their reserves are not enough to sustain that for an extended period of time. That information is available, and if you'd like to follow up after, we can give you that exact report. But that does point to a few hospitals that are in that very challenging situation. And one thing that Jed mentioned, and I'd just like to highlight again, the number that we gathered and reported to the legislature this year is in 2021, 2022, and through the early part of this year, the average cost of patient care is up 27.4%. So really, since COVID kind of kicked off, and then in fiscal years 21, 22, we saw a growth of over 27%, while again, those provider rates have remained in those low single-digit increases. So absolutely critical that we work to make investments in our workforce. We don't have this really broken supply and demand imbalance that's driving significant wage increases and creating space for more traveling companies to make their profit, and then make sure that we focus on rates that do keep up with the cost of care. Anyone like to address any of those other questions there?
Yeah, I can just add just a little bit, Jeremy, on the rural side. The numbers that we track and that we track in conjunction with your team would show that at any given time, about 10% of our rural hospitals fit metrics where they're in a critical state financially and operationally, where they could face closure. That was a number that we've seen over the last couple of years, and it's a game of roulette, essentially. The hospital that closed down in Oakland fit these models, and it closed. It eventually closed. And so we need to make sure that we're continuing to do what we can to support our vulnerable hospitals and our vulnerable communities, so that we can keep access for those individuals that are living there.
Jeremy, if I could just add one last, flip the coin a little bit and ask our friends in the press the following. I believe there isn't another industry that I would have chosen to work in, even knowing what I know today. And if the press could help us get the word out that working in healthcare remains a noble and very rewarding opportunity, and for young people as early as middle school to begin thinking about opportunities in healthcare, I think it could go a long way in helping us all as we move into the future, because the projections for nursing shortages, physician shortages, and other shortages in general in healthcare are daunting. And so the sooner we can get to individuals who start to think about those opportunities in healthcare, regardless of the role, I think we all stand to benefit from that.